Hello, my name is Peter Koenig, and I'm going to be talking about the coarctation of the aorta and neonatal considerations. I've got nothing to disclose. The goals of the talk are to understand concepts leading to clinical features of coarctation, understand the anatomy via 2D and stick diagrams, using the above to understand the physiology. I'm only going to do a quick mention of the anatomy in broad terms. I have some brief notes on pre-op and post-op management, and hopefully after reviewing the talk, the learner will be able to work through some clinical scenarios that'll be the active part of the learning session. So the problem, it coarcts a narrowing of the aorta, more specifically in the descending aorta, someplace between the isthmus and where the aorta bifurcates into the iliac arteries. This does not say that narrowing between the aortic valve in the body. Supravalvular AS, like in Williams, is not called coarctation. So for purpose of this discussion, I'm going to omit some things. Interruption of the aorta, and I'm also going to omit distal descending aortic coarctation, known as middle aortic syndrome, which is typically seen outside the neonatal period. So coarctations, from the Latin origin coartatio, or tightening, can be a discrete narrowing or a long segment, big distinguishing feature. I'm going to have some pictures of all that in a second. Pathophysiology will depend on the severity of the narrowing, presence or absence of the ductus arteriosus, development of collateral circulation, and associated cardiac lesions. So here's just a picture. First thing we see is an echo picture of an aorta, and this is on the upper right hand of the screen, and then there's a posterior shelf, and that's the coarctation, the essence of coarct. And that area could be right at the duct, which is here on this diagram number 3 in the middle of the diagram. Could be prior to the duct, right at the duct, or distal to the duct. And so juxtaductal, preductal, or postductal. And they've got the numbers for the various parts of this aorta. And that's pretty much as much of the anatomy as I'm going to talk about. You have to know about associations. It could be simple, just isolated coarctation, or it could be associated with other forms of left-hearted obstruction, mitral stenosis, subaortic stenosis, aortic stenosis. It's been described as including a bicuspid aortic valve, or VSD, and other intracardiac lesions. It's been described by Schoen's as a Schoen's complex and listed items on this slide. It can be part of other congenital heart defects like transposition, AV canal, hypoplastic left heart, and also it can be associated with other non-cardiac anomalies like intracranial aneurysms. I read that in textbooks, not something we typically look for in neonates, but certainly I think in adults they look at it more often, and that may be long-standing upper extremity hypertension. The clinical meaning, if there's obstruction of flow to the lower extremity, there's going to be reduced or obstruction to or narrowing of the aorta between the upper and lower extremity. You can conceivably have reduced flow to the organ systems, the lower half of the body, unless there's a way to get around it. So you increase the pre-narrowing pressure, increase the flow by increasing cardiac output, or bypassing the coarctation, PDA in the neonate, or collaterals in a child or adult. But if you have reduced lower extremity flow, you can have lower extremity organ dysfunction. Kidneys will try and compensate by reducing urine output, increasing preload to increase cardiac volume output, and they may also increase the blood pressure via the renin-angiotensin system. But there's not enough blood to the lower body. You'll have lactic acid production and organ failure. But also note that there's going to be all kinds of local and systemic regulations of resistance with the kidneys and the brain involved. Looking at trying to maintain blood pressure and maintain flow to the brain and to the kidney. So it's a spectrum of disease. We can have very mild coarctation that's undetected. Moderate coarctation may have some clinical findings. Severe really they're going to have clinical findings. Critical for sure. And critical coarctation is frequently associated with hypoplastic transverse aortic arch, may be associated with other left-sided obstructive lesions like mitral valve stenosis, subaortic stenosis, aortic valve pathology, and may be part of the hypoplastic left heart syndrome. We're going to go over that physiology in a different talk on single ventricles, as well as management of critical left-sided obstruction. I'm not going to really talk about that today. Concepts to know and understand. Coarctation is an anatomic cause of increased afterload to the LV rather than systemic vascular resistance, and it'll have a resulting cardiac response or compensation. With coarctation, there's an asymmetric cause of increased afterload. It's increased afterload it will be reflected in the upper versus the lower half of the body, and you'll have a gradient. Some things to understand also, you need to understand the transitional circulation of the components and the clinical findings, index of suspicion and ordering tests. You should understand the test, and I'm going to talk a little bit about management. So first, basic physiology, response of the heart to afterload. It's always the same. So remember, cardiac output is stroke volume times heart rate. Blood pressure is flow times resistance, Ohm's law. Stroke volume is influenced by preload, afterload, and contractility. An increase in afterload will cause an increase in contractility, or perhaps LV dilation as well, which will increase preload. And I would refer to our pressure volume loops, which we've done in past talks. So I'm going to digress on gradients and echo. In the echo, you'll just see the reports. Do we have a gradient or do we not? So, physiology of obstruction and gradients. And so these are my rules of gradients. In order to generate a gradient, you have to have just one path of blood flow. And so there cannot be another path of different resistance. Path that will, if there is, the blood will seek the path of least resistance. Rule 2. There has to be a force to push the blood across the obstruction. The force needs to be able to overcome the obstruction. In the circulatory system, it's the heart. Heart can't overcome the obstruction, and you've got heart failure. In other words, if you have poor cardiac function, you can't generate a gradient. Rule 3, time. If there's less time allowed for blood to flow across the obstruction, the force generated or the gradient has to be higher. So if the heart rate is faster, so there's less time per beat across an obstruction, the gradient's going to increase. Some other hemodynamic concepts, again, back to Ohm's law, and instead pressure is flow multiplied by resistance. Just put in systemic pressure, systemic resistance, and cardiac output. And back, remember, stroke volume multiplied by heart rate is cardiac output. Okay, so we're going to use these equations in different ways throughout. And again, the time and volume factor. Flow is related to pressure difference, and pressure difference are affected by diameters and are related to velocities. This gets into other principles. We're not gonna go into all the physics and math and all this. Just at least the concepts. So if I reduce the diameter of something, but I'm trying to maintain the flow, I've really got to increase the velocity across that narrowed segment. That's what we see by echo, and I'm going to see a gradient. And then flow can also be thought about volume divided by time. It's the rate at which a volume is delivered. So if we increase the flow by increasing the volume, the pressure difference across a narrowed segment will be greater. Similarly, if we keep the volume the same but delivered in less time, the flow rate will also have to increase, as will the pressure difference. So greater volume or lesser time to deliver flow across a narrowed area will increase the pressure gradient. This will result in a greater velocity across a given diameter. Next, our basic aortic diagram in numbers 1 through 5. 1 is the ascending aorta, 2, 3, 4 are the branches to the head and neck, and 5 is the descending aorta. So, ponder this. Why, if we have a narrowed segment, like let's say aortic valve stenosis essentially reduces the effective orifice of the aortic valve, we get a gradient. But notice between 1 and 2, we've got a narrowed, something that looks a lot smaller than the ascending aorta. Why is there no gradient? Think about that. Why is there no gradient? What's the difference in flow between 1 and 5? And I'm just going to wait seconds before I answer. Okay, so there's different flows. 1 is the cardiac output that leaves the heart. 5 is the cardiac output to the lower extremity after you take away everything to the head and neck. So 1 and 5 are different. 1 and 2 are different. 2 is the flow to the right common carotid. And left 3 is 2 is the right brachiocephalic artery and flow to the common carotid and right subclavian. 3 is the left common carotid and 4 is the left subclavian. So the amount of blood needed in those areas is different. It's not the entire cardiac output, so flow is different. So of course, by default, you don't need a big vessel. But the pressure in all those areas is the same. It's just the amount of blood flow going in those areas is different, and that's regulated locally. If the brain needs more blood, it'll vasodilate and you'll have more flow. And I bet the pressure will always remain constant. The heart will compensate to maintain that pressure, like the electrical grid. So here we have a same diagram, but with coarctation. And I just put QS, that's our symbol for cardiac output. But QS1, QS2, QS3, QS4, and QS5, they may be different things. Important, QS4 and QS5, they're really the same. Blood flow there, even though there's a narrowing, the blood flow remains the same, but we may be at the expense of a gradient. Or the flow will extend into diastole if it can't all be completed during systole. So you may ask, why doesn't blood go to the upper extremity when there's narrowing between the upper and lower body? Well, the upper extremity is only going to take what it needs. You may say, well, the kidney is going to increase the pressure. Yeah, it'll increase the pressure, but the flow is going to remain the same. So it's trying to push the flow across the coarctation, but the brain isn't going to require more of a cardiac output. It's just going to take what it needs, but the heart will maintain blood pressure. Okay, over time, you may be not acutely, but you're going to have upper extremity hypertension to augment flow across the narrowed segment. Again, the flow is, it's governed by other things. So variation in severity of afterload increase. If the heart is able to compensate for the increased afterload, let's say it's very mild coarctation, then stroke volume remains the same, and the only sequelae are findings related to the above. So the contractility may increase, the heart may dilate or have an increased preload, which may increase the LVEDP, which could have lead to clinical findings, but the stroke volume is okay, right? If the heart's able to compensate for the increase in afterload, either acutely or in the chronic state, the result will be an upper versus lower blood pressure gradient. The upper, in a way, has increased afterload, but you have reduced afterload in the lower half of the body. Similar net stroke volumes to the upper and lower half. So really, again, we're going to look at these equations. Flow is flow. The brain demands a certain cardiac output and pressure delivered, and the kidneys will retain more fluid in response to a lower blood pressure. The net result of all these compensations is an accentuated gradient. If the heart cannot compensate for the increased afterload, cardiac function may be reduced and the stroke volume will decrease. This compensated shock. The compensation is to increase the heart rate, and so you see that tachycardia and reduce peripheral perfusion and reduce urine output. Perfusion, when you're initially compensated, eventually perfusion and blood pressure will remain adequate, and it's just a sort of continuum. Decompensated, it's when there's hypotension, loss of consciousness, and you clearly have decreased central perfusion. Acute versus chronic. Acute increase in afterload results in a limited ability of the heart to respond. With a significant increased afterload, the heart's more likely to dilate and fail. It's acute. In addition, if there's cardiogenic shock, afterload could increase further due to endogenous catecholamines. Further, it's like a vicious cycle. Chronic increases in afterload include myocardial hypertrophy, which is a response to increased wall stress. That occurs because of a dilated heart and increased afterload based on Laplace's law. Hypertrophy will then decrease the wall stress and may improve cardiac function and contractility. In fact, you may see hyperdynamic cardiac function. So next, components of transitional circulation. PFO, PDA, pulmonary vascular resistance. Really, it's the latter two that are important factors in coarctation. So the fetal circulation, to review, we've got saturated blood returning from placenta, crosses through the sinus venosus and all that, coming into the right atrium. It's directed by the eustachian valve to the left atrium, left ventricle, into the upper half of the body. So the brain gets highly saturated blood. That's where most of that cardiac output goes from the LV. It returns desaturated in the SVC. There's really not a lot of blood going to the lower extremity. Most is coming from the SVC, and that's directed by the crista terminalis to the right ventricle. So right ventricle, the relatively more desaturated blood goes out to the pulmonary arteries with high pulmonary vascular resistance. Little goes to lungs, but that it's really directed to the PDA, desaturated blood, down to the descending aorta, and again back to the placenta. So you know the placenta basically does the oxygenation. So if you have coarctation, remember what I just described. There's separation of the circulations between the upper and lower half of the body. So coarctation in a fetus may not be a big deal. There may be some subtle things you can see, but it may not be a big deal. Now let's go to the neonatal circulation. Now we've got separation of circulations, and you can review this. It's the circulation everybody knows. Blue blood to the lungs, saturated blood to the body. Pressures are initially high in the right side, but eventually low, maybe 1/5 of what it is on the left side. So in this case, assuming it's not acute and severe, you're going to get a gradient between the upper and lower half of the body. So what happens with coarctation of the aorta during the transitional circulation? First, remember, PDA can be large or small. PDA is large in a fetus, involutes within hours to days after birth, may still be present weeks later. PVR can be high initially, then decreases. There's an initial rapid drop, but may remain high for days to weeks, and then naters in a couple months. The variables to consider in neonatal coarctation are the size of PDA, the pulmonary vascular resistance, the severity of the coarctation, and cardiac function. So let's talk about the size of PDA first. Remember, a PDA tissue, there may be PDA tissue in the coarctation itself. Thus, the coarctation may not be apparent until the PDA closes. That's why we always say pediatricians still need to feel pulses, especially in the neonatal period and certainly in the infant. You really need to be feeling, I think, femoral pulses in everybody compared to brachial, because who knows, it could be a subtle coarctation initially and takes time to develop. And they should be doing blood pressures as soon as you're old enough. Pulses are easy to feel. Do blood pressures when they're old enough to lie still. With large PDA, there's going to be equalization of systolic pressures between the descending aorta and pulmonary artery. Flow direction and amount is governed by pulmonary vascular resistance. There's a large PA. And if the PVR is low, there's going to be steal from the aorta to the PA. With a moderate sized PDA, there may be a mild gradient between the aorta and the pulmonary artery. Flow is dependent again on the size of the PDA and relative difference in PVR and SVR. The small PDA, there absolutely will be a gradient between the aorta and pulmonary artery, and thus the PDA is restrictive, and the amount of flow through the PDA is limited, thus limited steal. With severe coarctation, there's a limited ability to have the flow from the RV to the descending aorta by the PDA. I probably should make a little comment that there will be a gradient. I think when the PVR is lower, because initially the gradient will be masked by the elevated PVR. You can still have similar pressures in the PAs initially. So PDA and changes in flow with PVR. With very high PVR, flow across the PDA is exclusively right to left, PA to aorta. As the PVR declines, right to left flow becomes mainly systolic with left to right diastole. As PVR continues to decline, flow becomes mainly and then entire left to right. As the ductus constricts, aside from the direction of flow changing, the gradient between the aorta and pulmonary artery increases. The amount of flow in either direction is dependent on the ductal size and the difference between the PVR and SVR. And these are just diagrams showing a PDA of different sizes and high PVR. And I'm just making the point that in each case, we're going to have some desaturation in the systemic circulation because of that little bit of right to left shunting. Okay, the amount is going to be dependent on the size of the PDA and the actual pressure difference. And I just put a lot of this in for illustrative purposes. And I guess I could put in the arrow instead of purple. I can do darker purple, and it's too nuanced. I didn't do all that. With a PDA and mild to moderately elevated PVR, again, the size of the duct, and it's going to influence the amount of flow, but you're probably still going to have a little bit of desaturation in the lower half of the body. Okay, and it depends on, again, this is elevated PVR. So although I put in each case there is elevated pressures in the PAs, and I made these pressures up. I just want to show they're elevated. The issue here with high PVR is and then ductus size, you're going to have some desaturation. That's the point I'm making. When you have low PVR, and then we've got different size ductuses, look at how I did the picture here. In each case now, we're going to have no lower extremity desaturation. However, as the PDA gets larger and larger, we're going to have more and more equalization of pressures between the aorta and PA, and that's the point I wanted to make here. Now we just put in some point. So far we showed varying PVR and the size of PDA. Now let's add coarctation to the mix. And the bottom line, what I said before, is that the large PDA, the PVR and SVR are the major factors. With the small PDA, they're not. With elevated PVR, you see more right to left shunting. With low PVR, it'll be left to right. So severe coart. Here we are, severe coart. And so notice in each case, we've got desaturation to the lower half of the body. However, if the PVR is really high, we've got, in a large PDA, we've got sort of equalization of pressures between the PA and descending aorta, but not if the PDA is small. Because remember, the PDA will be restricted. In fact, the pulmonary artery pressure could be super systemic in this case, and the RV doesn't like it. I didn't put that in here, but that could happen. Now, when the PVR is down, notice now we don't have desaturation lower half the body. But notice in each case, there's going to be a gradient between the upper half of the body and the lower half. Think about that. It should make sense. In each one of these slides, you should slow it down and look at it again and see if it makes sense. If there's any mistakes, I hope there aren't any. I've been doing this, trying to take all the mistakes out of here, but let me know in the feedback. So with the severity of a coarctation, we've now seen what happens with severe coart in the prior slides. With high PVR, there's lower extremity desaturation. However, unlike a small PDA, a large PDA may mask a gradient between the upper and lower extremity, similar to a large PDA with high PVR and no coart. So it's masked. With low PVR, there's normal saturation in the lower extremity, but a gradient regardless of PDA size. In the following slides, I'm just have some had scenarios with moderate and large PDAs with varying degrees of coarctation. So here, maybe moderate coarctation and small and moderate or large PDA. And I'm making this up. This is all sort of now it's an in-between state. I think the part what I'm getting at, you're going to have to try and figure out what's going on. And again, high PVR, you're going to have some desaturation in the lower half. And you're probably, with large PAs, you're going to have equalization of pressures. But even with a small PDA, you're still going to have high PA pressures because you've got high PVR. You're still having a cardiac output. A big thing here is the lower extremity desaturation. As opposed to moderate coarctation with low PVR, you're going to have now, we're going to have normal sats in the lower extremity. However, now you're going to have some gradients that are going to be now exposed. Mild coarctation, I just put in there. You may not see anything at all. I'll leave it at that. Now, next variable is cardiac function. This is perhaps the easiest to understand. Poor cardiac function, there's not going to be any upper and lower extremity gradient. Pulses will be diffusely reduced. Blood pressure will be low, and there should be compensatory tachycardia. There should be tachypnea from the acidosis. This is shock. When presented with shock, you've got the usual differential diagnosis, one of them being cardiac. And so you always have to go through your whole differential of neonatal cardiac shock. And as you're diagnosing, you may be treating, and since you're suspecting cardiac, you may start prostaglandins and getting early diagnostic studies. Remember, with shock, the upper and lower extremity gradients may not be apparent until cardiac function is restored. Management, preoperative. Once diagnosed, so you first have the index of suspicion. The index of suspicion should, and we'll talk about in a second, should prompt you to do something. That something will give you what you need. So preoperative, once you diagnose, you have a management plan. In general, mild lesions are monitored, no intervention. Moderate lesions are likely to be intervened on, maybe not right away. Severe and critical requires urgent, emergent intervention. Temporizing management includes prostaglandins, make sure the arterial duct is patent. The duct could also be stented. Once the duct is large, management is supportive, paying attention to fluctuations in PVR and SVR, which will dictate a balance between oxygen saturation and blood flow to the body. And that's a whole nother talk, fascinating stuff. That's critical left-sided obstructive lesion talk, probably appropriate to hypoplastic left heart. Interventions, it's going to be something. It's either surgical or in the cath lab, surgical. In general, we do an end-to-end. We resect the coarctation segment unless we need to enlarge the whole aorta. And depending on the anatomy, the surgeon has to decide to go in from the side or through the sternum. We really don't do subclavian flaps anymore or interposition grafts, certainly, and not in the neonate. There's other things to consider. And interventional caths, maybe not so much in the neonate, although you can do balloon dilation, stent placement. Problem with stents is you outgrow them, and so you'd have to replace it. But stay tuned. Although the maybe cath isn't indicated neonate yet, I think it's been done in the past. Let's see, things change. New data, new ways, etc. Surgical risks, at least know about, aside from the usual bleeding, infection. There's injury to the recurrent laryngeal nerve, vocal cord paralysis, paresis. Recoarctation is when you do a neonate or repair, much higher incidence of record than if you're doing it in someone later. Rare paralysis from spinal artery injury. You can get organ ischemia from when the aorta is clamped, or just from the preoperative period when you had low flow to the lower body. Post-op management and supportive, allow recovery of ventricular function, follow for any acute recoarctation, look at your pulses, blood pressures. You're probably going to maybe get one early imaging study and uncover any acute issues, maybe a later echocardiogram and establish a new baseline. And don't forget about genetics, for instance, looking for Turners in all females, and family members who have, if there's a bicuspid valve, they probably all need to be screened. You don't need to do this right away. It's just as consideration. You can make sure you just let the pediatrician deal with all this after the child goes home. And you get the prenatal diagnosis or the questionable aorta. Sometimes, in prenatal diagnosis, we know for sure there's a coarct or hypoplastic arch. You're just gonna image to finalize the plans, and you're probably gonna start prostaglandins in a surgical date. With mild coarctation, or I shouldn't say posterior, I should say ductal shelf on echo, or a questionable posterior shelf. Remember that coarctation may be due to ductal tissue on the aorta. Can't always give a final diagnosis or severity until the duct is completely closed and involuted. So monitoring is patient-specific, but includes pulse checks at a minimum. As coarctation becomes apparent when the duct closes, remember that prostaglandin can improve a coarctation even if the duct does not reopen, because you're really dilating, relaxing that ductal tissue in the aorta, on the aorta itself. So what we're going to do is we're going to fill out some scenarios in the management section, and we're going to fill out some tables and some stuff to use. You can use these diagrams to help you out. And this diagram, I've seen the mistakes. You just have to do the math. And actually maybe part of the scenario will be figure out where the math is wrong. It all has to come back to work out. Okay, back to where we were. Clinical suspicion. After we're gonna go through active learning to help sort out presentations and clinical presentation. Once there's a clinical suspicion, the next test is an echocardiogram. That's the next step. If there's really a suspicion, besides getting an echo, you may want to get your cardiologist involved. Why? Because the cardiologist can facilitate next steps, can also look at the echo and see if it's a false positive or negative, and then really can help you out. However, there really you did this echo for something that is a question. Who knows? They did a neonatal echo, and now you've got this echo that says, oh, we can't rule out coarct because of large duct and whatever, but there's no suspicion. So it's one of those, if it's normal, the echo, it's easy. If we say it, then you're done, and you just go back to your surveillance mode to try and pick up something that we didn't know before. So you always have to have your eyes and ears open. It's an abnormal echo, you're going to know about it, and that's probably going to be time to get the cardiologist involved. It's the not clearly abnormal echo. It's the ones we cannot exclude coarct. You're stuck. Now you're going to have to use some clinical skills, and it's just some picture of what looks like discrete coarctation and posterior shelf here. And there's also a little ductal shelf. And so, we was always looking at remember a big ductus, I can't tell. So, if the coarctation's there, we'll let you know. But sometimes there's arch looks okay because of a large PDA, and you just don't know. Um, and you don't know until the PDA closes. And remember, it can mask things. So you just, you get this. I always put residual remnant. I keep on saying posterior shelf. This is a mistake. It's actually ductal shelf. I'll have to correct it in the next version. And the isthmus of the aorta is not well seen and cannot tell if there's a posterior shelf. This is a typical Coarctation watch. Allow the PDA to close, become very small, and only have left or right flow. And then from our scenarios, you should be able to exclude a PDA. You're never off the hook. And you need to make sure there's no significant aortic hypoplasia, because that'll be a tip off there's something there. And you do follow up until the, I should say, ductal shelf or the ductus involutes. And you may have to just make sure the pediatrician sees the baby maybe weekly. If there's some more suspicion, maybe sooner. And then your frequency of follow-up will decrease as the baby gets older, and you let go at some point. And just initially, and I can't. It's hard to dictate. We try and give some people an idea. First, just see them soon, then weekly, and if there's some suspicion, try and get off the pot at some point. So the consultant, and the reason to help get a consult, it should be able to correlate an echo with a clinical finding. Should be able to direct the need for other testing. Should be able to direct the need for intervention, medical versus cath and surgical. Once a coarctation is diagnosed, you're going to start prostaglandins if it's severe, and you're going to manage like a critical ductal dependent left-sided lesion. That's just another talk. You're going to always have close attention to the lower extremity pulsations if it's not deemed ductal dependent, and frequency evaluation decreases the time, and if the PDA is closed. So treatment intervention, like I said, it's either cath lab or surgical. You need to know the anatomy, so the surgeon knows how they're going to go in. The cardiologist, the interventionalist, needs to know the same. The anesthesiologist needs to know about functioning hemodynamics. Post-intervention, repeat all the pre-intervention steps. You need to know the intervention, redefine the anatomy and any residual coarctation when you're looking at imaging again. Look at the associations, look at the hemodynamic associations. In summary, coarctation may be a cause of neonatal shock. The workup of shock will lead to cardiac if that's the case. Physiology of coarctation is one of afterload increase, but altered by the degree of the coarctation, and the neonatal, the transitional circulation state, and the rapidity of onset. So you need to understand all that physiology. Hope this talk helped you out. Coarctation may be more subtle. Management is dependent on all the components of transitional circulation and severity of coarctation. Thank you.